Good morning, good afternoon, and good evening, wherever you are. My name is Chris Wynder. I'm the director of marketing for OpenText. And today we wanted to give you an opportunity to hear from some of the industry experts between Amanda, Scott, and I. We probably have just about over half a century of expertise in healthcare and software implementations. We wanted to give you some insight into really what the process looks like and where we're seeing gaps today. All three of us are still actively talking to healthcare customers and healthcare product engineers. And we thought it'd be good to give you, as you kind of look at the services and everything, an idea of where there's gaps, what the patients need, what the doctors need, and kind of looking at those things that are universal, not just US based or not just India or any of our other localities, but really talk about the generalities, the things that will be really interesting products that we're really looking forward to seeing out of this. Myself, I am a doctor. I've been doing clinical research or working with implementing ECM and information management systems in hospitals for about 20 years now. And I'm going to hand it over to Scott to give us an introduction on who he is and what he does.
Hey, everyone. Thanks for joining us. So I'm Scott Lundstrom, longtime software developer, technology analyst. I founded the healthcare technology research business for International Data Corp about 15 years ago, and had leadership positions there in AI and cloud as well. I've worked with a number of large plans and IDNs and health systems on their cloud and digital transformation journeys, and it's a pleasure to be here today.
Thanks, Scott. Amanda.
Great. Good morning, good afternoon, everyone. My name's Amanda George, and I'm one of the senior product marketing managers here at OpenText. I'll be coming in from the perspective of more the patient experience side. I've got a lot of experience dealing with the frustrations of the healthcare systems, and my frustrations have actually led me into this conversation today, which is very timely as I kind of go through my own personal qualms with the healthcare system and their systems, along with what I want from a patient experience to make my life a little bit easier.
Great. So the way I want to structure this, and the panelists are aware, but for the audience, is really I want to have it as a series of conversations. We're going to start big picture, and then we want to bring it down to what do you need to know to succeed in this hackathon. So I'm going to open it up to Scott and Amanda first, and just, Amanda, from what you've been doing over the last 6 months and the conversations we've had and the conversations you've had leading our podcast, what do you think is the state of healthcare right now?
I would say the state of healthcare is in a very desperate stage. And I can speak from experience also going through the pandemic and having COVID myself. What I saw happening in our healthcare systems actually is pretty alarming. There's a lot of changes that are impacting not only just the clinicians and our nurses, but also cleaning staff. I think everyone in healthcare is really impacted by not only the digital changes, but also the changes implemented throughout the pandemic. I'll give a perfect example. Machinery is something that, healthcare practitioners rely on heavily. The cleaning solutions being used during the pandemic was actually limiting how much information those machines were actually transmitting to the nurses or doctors or anyone else that needed that information, because those cleaning solutions were actually dissolving part of the sensors, so it couldn't send that data to the nurse. So perfect example, I'm on a heart monitor. I'm lying in a clinic bed in a hospital. And, you're supposed to get an alert every time a patient has, heart rate over X amount of beats per minute. My machine is screaming at me, but none of the nurses are able to hear this. So I had to physically chase down or even just, scream at someone, hey, can you call a nurse? I'm like, my heart's hurting. This thing is going off. Shut it off for a minute. So there's some of the problems that kind of lie there. But, in addition to just, the equipment issue, we also have the digital issue. I think one of the biggest problems that I have, especially as a patient, is dealing with the digital gaps, because as all of our doctors, whether you see your family doctor or a specialist, those notes all live in separate different data lakes and are not cohesive and brought together. So I don't mean to be rude to my, the doctor in the ER, But unfortunately, he doesn't have access to all of the information. And he's frustrated with me because I'm trying to explain what's happening. None of us know what's happening, but he doesn't have a point of reference to go back and say, hey, you know what? I've got all your records. I can see this. I saw that you already saw the cardiologist. I saw that you saw this person. He doesn't have that frame of reference. So it gets frustrating for both the doctor and myself to have to go through my entire health records and my history. And I've got to do everything from memory as well, because the other fun part is if they do have digital records, there is no classification system.
Yeah.
So I know my dates of hospitalizations and the month. I'll tell them, be like, all right, 2016, this hospital, this date, this time. Now they got to go scroll through a long timeline. And I got a lot of visits, unfortunately. They've got to scroll through from 2023 all the way back to 2016 to go find that specific record, because it's not, there's no metadata tied to any of these medical documents as well. So from a patient experience, it is very frustrating when you're having to deal with a doctor, but also have a plethora of medical records that cannot be accessed at the same time.
Yeah, it's an interesting point, isn't it, Amanda? I mean, you know that the data exists. The doctor actually usually knows the data exists. The hospital knows the data exists, but there's no way to get it. And Scott, that's a segue over to you, because these are conversations that, you know, as part of the healthcare forum you've been having a lot lately. I'm wondering what your perspective is.
Well, so let's go up 100,000 feet from the failing medical device, right? It's hard, and you know, I want to remind everyone that it's not the health system participants that are at fault here. All right, this is a case of hating the game and not the player. All right, and the game, especially in the North American health system, is changing really quite radically. There are these tectonic plate-like issues here, right? Aging population, okay, growth of managed care. The fact that a significant portion of the care we deliver now is around managing chronic disease. And what we've done is we've created a system where we have growth now because the population is living longer, and they're living longer with disease, and we're to some extent becoming a victim of our own success. All right, and now we layer all the other issues of the day on here, right? If you look at our providers, they're losing money on patient services. They have low financial reserves. They have rising labor costs. They have increased inflation. And these are all contributing factors to this really difficult business model. So they're left with very little choice, right? The only upside in the market now is to pursue what are called value-based agreements with large payers. Okay, value-based requires us to manage health, not treat disease. All right, and the model is really based on the fact that through use of data and engagement and more proactive management of care plans, we can reduce utilization. We can reduce the actual fee-for-service component of the business. Participants are paid on an annuity. They're paid for managing a panel. It's a per patient per month kind of wellness payment. They do better. All right, physicians that had risk-based agreements under COVID did much better. So it's tough because the demographics of the market are changing, the reimbursement models are changing. But the part of it that's clear is the only way to succeed is to use more data, to run a better process operation, okay, to do better on the clinical performance, and do a better job of engaging, and especially engaging those expensive patients, those chronically ill patients, patients that suffer due to social determinants of health, patients that have healthcare inequities, people that need an additional push to maintain a care plan for what otherwise is going to be a really expensive chronic disease. So, you know, it's a challenging market, but it's a market right now that favors automation and data. You know, we just did a big announcement with Google today, extending our relationship with them. And, you know, I think, you know, we really serve a tremendous value in terms of being a content pump. And, you know, what the market's trying to figure out now is, where do I find the content? How do I plumb it? All right, how do I access it? And you know, I think it's going to be exciting times. Generative AI is going to is going to change the market as much in the next 10 years as electronic medical records changed in the last 10.
Yeah. And I think, I think what I'm hearing from the two of you, if I try and boil it to somewhere between street level and 10,000 miles, is that, there's this area where there's a lot of opportunity and there's a lot of need. And it's actually one of these weird points in time where opportunity and need match up. The hospitals, the people who spend the money, need better ways to create, if not revenue, depending on your market, create the opportunity to have a zero sum game. And the doctors need more information to be part of that zero sum game. And the patients need the doctors just to have the freaking information so that you don't have to carry around a wallet of paper with you every time you go. So I think that segues nicely into the next topic I wanted to ask you both about. And so if we talk about the care team, so not the hospital administrators, but if we talk about the doctors, the nurses, the care practitioners, and maybe think outside of the hospital, we're talking about the people that you deal with every day. Where's the new problem? What's the data problem that they're having? Because Scott, as you articulated, there's a problem there for the doctors. They need more data, but we've all three of us have seen situations where you just data vomit on somebody and they just don't get it, right? It's just a problem. So Scott, when you think about it and you talk to the large clinics, what are they trying to do for their doctor, and where's that gap still?
Sure. So, I mean, I don't want to oversimplify it, but a big part of the problem in healthcare is that there's so much unstructured content. Yeah. Right. I mean, think about what happens when a patient presents at a emergency clinic or at a hospital, right? They have a driver's license, they have an insurance card, they might have a referral, they might have a bunch of records. I know people that carry around their past EKG because they have they want to be able to document a heart abnormality, so they're not admitted if some physician sees their heartbeat. It's really interesting,
Amanda.
Yeah, it is really interesting, and all of this creates this tremendous disconnect in the health system, right? Think about what happens. All of this stuff probably gets scanned, and that PDF gets put somewhere. All right, and I mean that, somewhere. Oh, yes. All right, and nobody really knows what it is anymore. So we would advocate a process where we actually discover, we capture the data. We pair that repository with, that document in the repository with an XML or JSON expression that says, hey, this is what I think this is. Here are some of the key data elements. Same with imaging. All right. A lot of the knowledge in the imaging is in the notes. All right. Getting to a note in an image is nearly impossible. So we really see, one of the greatest goods, that we're doing out in the market right now is simply turning content into data. All right. And the minute that data is expressed, it can be used. Right. So in engagement, all right, we can see what someone's doing on the website. We can see how they're interacting with the portal. We can send them questionnaires. We can ask them and advise them about new opportunities for them for care and education. We can't do that if we don't know how they're interacting with us, right? We can't drive that engagement. The same with the care team. All right. I work with facilities all the time, new up on Epic. Well, what happened to the last 40 years of history on some of these patients? Well, it's out there. We couldn't afford to migrate it, but it's out there. So every time they have to do a release of information, every time they have to prepare a packet for a surgical team, someone's got to go touch that legacy system. And that means I have to maintain it. And that means I have to stay current on license. And that means I never get the ROI out of my new system. So again, the ability to capture that and organize it and honestly to then shut down those legacy systems and create that core or centralized repository of content and data, that's a tremendous benefit right now. And the bigger institutions have already figured out that this is an essential precursor to Gen AI. And they're moving very quickly. Right. I mean, everyone wants to take one of these new certified models, let's say a POMMED or something else. and have a way to just load their data, right? Mayo wants a specific system. Kaiser wants a specific system. United wants a specific system, right? They want it built and trained on their content. So, all of this now has gone from being interesting to being essential in a very short period of time. And, everyone's trying to figure it out.
Yeah. Yeah. And Amanda, you and I were both laughing because I feel like I've heard the story that Scott told in a much different way from your perspective. So maybe give the audience a little bit of the other side of the coin, but maybe thinking about how that impacted the care team's ability to get you what you needed.
Yeah, I mean, my care team unfortunately works with a lot of broken dispersed systems, which makes making care plans for me difficult as well. But a very funny story, you talk about data segregation from a patient experience. I don't care where your data lives. I just want my data. Because right now I'm getting to the point where I'm frustrated. I don't know how many years I'll be on this planet, but I've already been on this planet for, a few decades. And unfortunately, my health records are not up to date. And recently I went to one of the hospitals that I go to on a regular basis who just did a migration from Epic and redid their system. And I had to go re-register as a patient. Even though I just done registration and updated all my contacts and information last year, I go to the hospital this year. They did that migration through Epic. And then, oh, is your family doctor so-and-so? I was like, hold on, who? That was my first doctor who passed away in 1995. I was like, hold on, this hasn't been updated since 95. So what records do you have now? And that to me was shocking. One of the things that I've done as a patient, and I actually do have a massive folder behind me with all of my health records, I asked for a copy of everything because as a patient, I don't care where the data lives. I don't care what system it is. As me as a patient, it's a very frustrating experience to talk to a doctor. Something as simple as blood work, for example. You have, I don't know, I've done more blood work than anyone has probably done in their lifetime. I don't have a way of trending this data, hence why I take a copy of it. I then upload it and then actually made a Tableau dashboard that trends my red blood cell count, my white blood cell count, my NCV values, my NCH values. I'm becoming my own doctor. I know where my normal is because the argument I also have as a patient is that there is the medical norms and ranges. It's like, oh, if you have a hemoglobin count of X to X, this is normal. That's your normal. My normal is way below this. And I know this. And I know that every time I go to a doctor, I don't mean to sound like a douche, but it's like, yeah, by the way, when you run that blood test, this value is going to be off. This value is going to be off due to this, this, and this, because that doctor is not aware of any of my medical premeditated conditions. But the other thing that's also interesting that I've found watching all of my doctors, whether they are specialists or, my physiotherapist that I see, or some of my external outside of the healthcare norms, sort of practitioners kind of work within different systems. These systems are really cumbersome. The amount of times I sit there and half my appointment is wasted on a doctor being like, I don't know, this button, it didn't do what I wanted it to do, or I can't save it. These systems are also super cumbersome and they're not easy to use, therefore making it difficult for the doctor to do his job properly, or the nurse to update her notes, or whoever else needs to input something into the system, because it's not an easy, oh, there's the patient file, here's today's record, let me just add a note to it. No, it's a whole process to go through. So also the design of the system is impacting how quickly practitioners can actually deal with a patient, which is also impacting their time with me.
And I think that's an important thing that I found frustrating is you spend, you go to see normal checkup. Maybe you're early on something. Oh, I've got a pain in my side, or this has been happening. And you spend half the appointment like this. You're talking to the back of their head because they got to be at a keyboard because it's keyboard based and some other things. And when we talk about that patient experience and the role of the clinical practitioner, whether they're a nurse practitioner, a nurse, or a doctor, and they're taking your information, they're not actually taking your information. They're just transcribing what you say. They're not getting the chance to process it. They're not getting the chance to look at you and have an interaction. And the value of why we train doctors to be doctors is often in they're giving them that insight and that ability to contextualize, for example, your information, Amanda, where no, my norms are not, 125/80, they're this. that's fabulous information. That tells you that there's something, if you're below or above the normal number, that's not a path we need to waste our time on, right? So it goes back to that risk base, Scott.
And
I'm
just a second,
wondering, yeah.
these things are great. I mean, as a patient, I think as we become more accessible to our own data, we really do become the masters of our own healthcare in our own way. I know for me, and this also comes, I mean, there's other topics we can go offhand and talk about when it comes to, collecting data via these wearable devices, et cetera. They are a huge part of my everyday. I track my food intake, my water intake, my calorie intake. Unfortunately, my dietitian hates how little I eat, but that's just my norm. Like, that's
Yeah.
just me. I know I'm supposed to have, 1,400 calories a day. Most days I'm coming in at 700. She's alarmed. I'm not. I mean, I'm still a functioning person. Nothing's quite wrong yet. But there's those working norms. But in addition to all of these things, the nice thing about these types of devices, I've got an Apple device. There are the Android devices now that do have these healthcare kits that I can now connect into certain clinics. So if the clinic or the hospital has that system, what I'm frustrated with is the data coming back from those systems because it's not usable in any way, shape, or form. So, you're scanning a document, take a blood test, and I actually have a requisition sitting right in front of me telling me I need to go do it. But you take this requisition, if you could somehow transform the metadata from this requisition into something usable, this actually saves me and the doctor time from having to sit through and, waste 5 minutes of the appointment reading through the document. Oh, okay, yeah, all right, cool. And then rushing you through. Because unfortunately, one of the downsides of having a free healthcare system is the mandates also set out. A doctor's only supposed to spend X amount of time with a patient because it costs too much money. 10 minutes is not enough for me to go through everything with my doctor. Unfortunately, I'm one of those space cases that we're going to have a long conversation. It's probably going to eat into 2 other patients' times. But unfortunately, they don't get billed for that either. So therefore, they're rushing me out the door. Okay, like you got 1 minute, hurry it up. Let's go. Here's your prescription. Bye. So there's these.
And there's the other side of that, right? Is that I hear from colleagues who are doctors and some of the clinical researchers that I've worked with in the past, and Scott, you and I have had this conversation before. They don't, even if they had a longer appointment, they don't have time to do the in between, right? So you have this real uncomfortable problem for the doctors. Is what is the scannable information that is highly valuable at this moment? If Amanda came in about this problem, how do we decide whether that's a problem where there's a next step, or if that's a problem that should be that's just her norm, right? And so I know, Scott, you, depending on what you can talk about, I know you've worked with a lot of doctors. I know you and I have we've both been to doctors. I wonder what your perspective is on that kind of scannability and the patient experience.
Well, again, it really comes back to personalization, right? I mean, it's an uncomfortable truth that our electronic medical record systems were built to generate bills. All right, they're revenue towers. All right, they were not built to drive clinical excellence at the boundary of the patient interaction. They're just not. All right, we count on physicians for that. Right. I think unfortunately now we've created a system where the physician has to spend too much time feeding the beast. There are some really interesting new developments where big health systems are trying to figure out how they drive the keyboard out of the room. And there's some privacy issues here, obviously, but through cameras, through microphones, through changing the nature of that clinical interaction to be a little more face-to-face and a little more verbal and more interactive, that we actually capture data automatically. All right. And we give the physician that freedom to exercise their great skill, which is that interaction with the patient. But we catch the data, right? We don't make them sit there, and we're not treating physicians like data entry clerks. And that's a big part of the challenge in the current system. So, the more we can capture from the air, and again, this is basically, when you think about it, it's about APIs, creating digital content and feeding them into well-trained machine learning environments. And that really could change the nature of the engagement. With some of the big payers now, where we do, customer specific messaging and engagement around chronic disease, those have been very successful. Where the patient really thinks you empathize with them, you're delivering personalized advice and context to their needs. That changes the relationship. They become more loyal, they become stickier, they become more compliant patients. So, I really think healthcare could change dramatically over the next 10 years. We just have to figure out how to let doctors be doctors again.
Yeah.
Yeah.
And we actually just did an episode on the podcast recently with a gentleman by the name of Evan Pankey, who actually has his own Medicare sort of facilities where he is completely digital, completely remote, and has everything built out. And these are things that people don't think about. I think one major shift that we've all seen due to the pandemic is taking patient care outside of that clinic. You can actually make it more accessible. We're talking about patients with chronic illness. They are more comfortable being in their home than they are being in a clinic. And if you can bring the patient care experience to them, which is exactly what Evan's company does, he's got all the equipment, the Wi-Fi in case the patient doesn't have Wi-Fi in their home. It automatically connects to the systems. The doctors and the care team can come in and enter their notes as easily as possible on an iPad, leave the iPad there with the patient so the patient can enter their own notes as well while they're not there. So if anything does arise while there isn't a caregiver around, they're aware of it and they can actually send help right away or do something about it. We're also seeing this massive shift as well, because I know from personal experience here in Ontario, a lot of doctors were forced to go back in clinic because a lot of doctors, actually family doctors, have quit and are going into online systems. The billing is the exact same. If you were a doctor, do you want to be in person or do you want to be online? If it's a 5-minute phone call with someone online, you can take more patients, which means more billings for you versus now you're in a clinic, patients are late, they don't show up on time, you're not getting paid for those hours or those minutes, etc. So the push from OHIP to get, doctors back into clinic, is it actually helping us or harming us? What was the harm in keeping doctors online? Because to be honest, I would rather have a 5-minute conversation via Zoom with my doctor just for the results of my test or whatever. I don't need to go in person for that.
Yeah, and I think there
this
needs to be
is
a
the
better balance, right? I think there are some things that absolutely have to be hands-on. And I think the ability, I think what we're all kind of saying is we need the flexibility to get the right match for service versus outcome, right?
Right.
And it's interesting. I think we've seen some models in some other countries that are interesting, but I don't know if they translate universally. I don't know, Scott, what you think about that kind of.
Yeah, I mean, it's interesting because the move to value-based has definitely caused health systems to think a lot harder about services like hospital at home, and remote chronic disease management. We all know people that have hypertension or they have a history of CHF or they fight with their diabetes. And often that thread of data, right? That 2 time a day, blood glucose measure, that 4 time a day blood pressure, is really all that's needed to maintain their care. You get into well-managed diabetics, they go from in-person with a specialist, an endocrinologist, to remote with their PCP. That's a huge cost savings. So, I really do think there's significantly more interest now. And then that's being driven by the nursing shortage as well. There's a huge shortage of SNF, of skilled nursing beds in the US right now that are delaying discharges and screwing up everybody's length of stay numbers. And so, the move to any kind of home-based health delivery is going to be beneficial. And Amanda, it's so funny. At last year's HIM, Best Buy announced a division that works with physician groups to go wire patients home. You can call Geek Squad and get your hospital at home set up in the US now.
That's a smart move. I mean, it's better than the CVS move with Theranos, so I'll say that. But if anyone remembers that,
You don't say that word. That's a dirty word in healthcare.
No more. But I mean, that's a genius move on Best Buy's part. And I think as we kind of move forward, especially in the tech space, we're going to see a lot more interconnected spaces. Like, I mean, hell, my Apple Watch was the one that actually dialed 911 for me one time when I fainted. And it's a feature I am thankful for because, I mean, I'm only in my 30s. I don't want a life alert just yet. If this is my alternative, I will take it. So I'm for it. I'm happy to have this thing.
And I think what's one of the interesting things, and as Scott and Amanda will both know, I spend probably an embarrassing amount of time reading about healthcare gadgets and what's going on in different systems. And I guess I'm going to throw it out to both of you. What do you think? I've seen a couple of really interesting articles on the fact that we actually don't need servers and PCs for healthcare anymore. We could do this all on a mobile device, whether that's a tablet or a phone. What do you think conceptually? So if we take the hospitals out of it, which I think is a different animal, what do you think about that from just a big picture, from a patient perspective? Would being able to work off of a tablet or a phone where you could snap the picture, you could share it with the survey and those kind of mobile apps, would that kind of design, would that fill the gap, or is that just kind of redirecting the gap?
This goes back to a conversation I think you and I and maybe a few other guests on the podcast have had conversations around, where we talk about the human approach. I think by design and by default, we are centering our lives around smart devices. So it makes sense why that is the move. I mean, if you think about it, you can't do anything without your smart device anymore. And especially me, if this wearable is able to track all of my information and take it all in, and I just have to input it on my phone, that is the easiest way for me to manage it, which is absolutely true of today. I mean, like I said, I track my water intake, my food intake, my macronutrients. Oh my goodness. I'm a nerd like this. And I've been tracking my data for the past 15 years. I won't talk about the weight data. That one is the most saddest attribute point I've looked at. I've only watched my weight go up over the last 15 years, but other values, for example, that I can track, I think it's interesting when I look at my own macronutrients, I can kind of correlate based on what I've been eating, where my weight gain has been happening. And it's really funny because even just like little changes in my day-to-day activities, I can attribute that to, oh, okay, well, I didn't exercise enough these couple weeks, hence my small spike in my weight gain or whatever the case may be. But I think it is one of those things that we can center our lives around because it's always in our hands. I mean, when do you not have your phone or your device with you? It's so easy to just snap a picture, to upload that document, to automatically track. I mean, I've got an auto sleep tracker. I'm an insomniac. I don't get a lot of sleep. For the past 15 years, I've been giving my doctor the sleep reports from my fitness device, whether it was my Fitbit or my Apple Watch now. The Fitbit is much more accurate, I will say that. There also is a device differentiation too, because I've been testing this out for a couple of years just by myself, but there are slight variations. But I think overall, these devices have definitely gotten a lot smarter with, the blood oxygen levels and the heart rate. And I can even do an EEG on the spot, which is very helpful, especially when I think, with these devices, they all have some level of mindfulness built into them for patients, mental health patients, or anyone going under stress. Those little reminders to breathe and being able to track or do an EEG on the spot to make sure that you're not dying, just to prove to you, hey, this is not a heart attack. This is probably an anxiety attack. Just breathe. That's it. It's a helpful reminder. So there's little things that are coming into these devices that are making our lives easier to kind of manage.
So what do we do for the non-geeks? Because we're kind of a biased sample here. We work in technology. What do we do for the non-geeks?
This is where everyone on the call comes into play, because you guys are those automated features for us. Like, I mean, a couple of years ago, you didn't have a breathe reminder. You didn't have the Calm app. You didn't have these triggers based on, and again, taking medical data. If we know that every hour you should stand up, that is the recommended, recommendation that you should stand up for at least 5 minutes every hour. Well, yeah, build an automated thing that gets sent to my phone that tells me, oh yeah, you should stand up. You've been sitting for too long. This is taking those medical ranges and those norms. If we know that 4 glasses of water a day based, and again, customization also gets played into this, you have all the information at your fingertips. I am a under 5-foot woman, X amount of weight. This is how much water I should take a day. It'll remind me on my own. And that was something someone else created where it made my life a little bit easier. I don't have to think about this. I can go about my day to day, but that reminder is there because someone built it for me based on range. And we've seen examples of someone in New York, for example, who built out an AI bot to detect cancer before even a human could. They're taking
Right.
digital, diagnostic imaging and comparing them time over time. And they were actually able to detect breast cancer in a few women years before the doctor could.
Yeah.
Sure.
So if they had caught it when the AI machine had said, "Hey, something doesn't look right here," that patient would have went and said, unfortunately, a few patients were diagnosed at stage 3 or stage 4. They could have caught it as early as stage 1 or stage 2, and
Mm.
it could have impacted this person's life. So you're seeing some of these advances where people are taking the existing diagnostic images, the existing tests out there, turning them into transferable data, and then creating these triggers or reminders that are now being passed out to the patient.
Yeah, and Chris, this is a place where I mean, it really speaks to the fact that we have to mature the back end to some extent, right? We have these
Yeah.
great devices. If you're a geek, you can get real value out of them. If you're not, you wear it for 2 weeks and it winds up in a drawer. And that seems to be the outcome of 90% of Fitbits. And at least a watch is a watch, right? I think people just stop using those features on the watch sometimes. But the challenge is, how do we harness that data and turn it into something we can actually learn from? Right. And so if we take all the Amandas and then within that group, we find all the geeks, and then we aggregate all that data and put it in the hands of a clinical researcher. And we do that with all respect for PHI and HIPAA, and I believe it's PEPITA in Canada. And, but we create a base of data we can actually begin to learn from. And I think that's, again, one of these big opportunities we're going to see as content gets digitized, as more of these backends go into standard API accessible cloud architectures, and as more physicians and patients become engaged, in their care, in let's say the way Amanda is, where they're interested in the data and they'd be willing to talk to others like them to see what's the same and what's different, and to drive progress forward on that pathway. There's huge, tremendous opportunity there. And not too far from now, the machines will be doing that on their own, right? There'll be algorithms that go out and seek cohorts. There'll be algorithms that go out and try to learn from those assembled cohorts. And it's going to be a remarkable time. I really think I'm excited about it. But it all comes down to what we're doing here today, talking about how we make data open and we build APIs and we make content digital. And, those are all really worthy goals.
Yeah. And I think that's a great place to stop. I'll have a couple of final remarks, and then I'll let Amanda and Scott give you their take on where it goes. I think what I heard today and what I've been hearing from some of the doctors that I've talked to for this audience is it comes down to there's a lot of really simple things that would make a measurable effect for both clinicians and for people. It's about getting the existing data into a way that can be shared by either the doctor or the patient. That's capturing it, OCR, turning it into machine readable, making it ready for AI. Just that contextual stuff is high value. And then on the other side, you have how do we make it look the same so that I can share it with a patient, I can share it with a doctor, and we're both working off the same base logic. And then that makes it prepared for the Palm Med. That makes it prepared for all these other things that as a plug, we'll have the Google Health API expert and one of the Google implementation experts talking at this time next week. So for me, it really comes down to this idea of machine readable, whether it's unstructured or structured, and putting it all into the same metadata type so that it can be combined by whether it's machine or person, is really high value and can be done with today's technology without really kind of overextending what today's technology. Amanda, I'll give you the next one, and Scott, I'll give you the last word.
Yeah, I mean, if there's anything to take away from this call, it's definitely we need to kind of create better models for the medical community. I think we have a lot of unstructured data that definitely needs to be structured in a much more fashionable way, whether we can transform even something as, simple as a requisition, all of the metadata tie behind blood. Let's take blood tests, for example. That is probably the first line of defense in everything. You have an issue, we're going to run a blood test. If there is a way to structure the results in a better format and have it displayed for practitioners, that's our first line of defense. And I would love to see that happen in the next 5 years, because I think that's the first starting point when it comes to most medical discussions anyways. And just seeing how unstructured a simple blood test is today, that's alarming. If we can structure that data better and then be able to trend it, I think it would be a much more fruitful conversation for not just patients, but also for medical practitioners to also, have a baseline to start with in order to create custom care plans for patients as well.
Scott?
Yeah, I think it all comes down to, the model of the future is one where we try to engage more frequently. We try to operate more proactively. And to do that, we have to build a relationship with patients, right? We have to get to a level of engagement. We have to talk to them on the channels they want to be on. We have to communicate with them in the way that they want to be spoken to. There's tremendous kind of move toward personalization of care. I mean, to Amanda's point that, we have a consensus view on what my condition is right now. Right. And the health system, the payer, myself, we all agree on that. Right. That's a long way off. But again, it is a worthy goal. And, I think that's what we're going. There's a lot of forward movement with FHIR, with the 21st Century Cures Act, with improvements around patient access to their own information. Well, if the patient can access it, then they can give access to it by proxy to someone that wants to do interesting things with that data, like clinical researchers, like, AI and ML companies trying to drive forward specific, objectives from a health perspective. Imagine if every diabetic in this country would share, their data with a company trying to create a very inexpensive insulin replacement, right? That would be a worthy objective. And, with the right infrastructure, we could do things like that. So I'm kind of excited about where we are now. This digitization of content opens a lot of opportunity, and hopefully the system will work better by the time I retire.
Well,
There's
Scott,
actually smart, what do they call the diabetic little tests that they do?
Yeah, right.
There's smart devices now that are doing exactly that. So I think we're starting to see those changes. We're starting to build momentum. We just need more people like everyone on this call to help us shape it. That's all.
Right.
Well, with that, I really appreciate your time, Amanda, Scott. For the audience, happy to continue the conversation. We have the OpenText Developer Forum set up for the hackathon if that's the way you want to interact with us. We've also got a Discord server, and it's actually in the chat if you're interested in having more of a live conversation. So, and I do see one question. I think it's a good question for this group, and we have a couple minutes left.
Yeah.
Nowadays, hospitals are turning to FHIR, FHIR, for those not in the healthcare field, HL7 data format ingestions. How effective is this implementation based off of user feasibility, data confidentiality, and security? So I think he's talking more so about how does FHIR fit into that picture, and if we are going to do something more of a mobile and some of these other things.
Sure.
Where is the moment for developers?
So I mean, honestly, I think in all things security, right, the user is the weakest link. So obviously, a patient has the right to pull down records on FHIR. They're on their mobile device. We can't do anything with what happens to it at that point. It could be shared. It could be left open on a table. It could be stolen. It could be hacked. So, I think there are some device specific issues that we have to think about there. And what does a real robust container on the device look like for that data? Otherwise, though, I mean, most HL7 communications are absolutely covered under HIPAA. Certainly where we ran those on our networks, it would all be SOC 2. You know, it would all follow a NIST framework. I think you find most managed service providers in healthcare have to sign BAAs, and they are pretty serious about cyber.
Yeah.
And again, you find most breaches are at the end point, right? Someone opened a piece of dirty email, they infected a piece of malware on a local PC in a facility. So you know, the security can be very robust, but it's really about the institution, right? Who manages their communications, who manages their servers. And it's not even just so much hack now, it's ransomware and recovery, right?
Yeah.
How robust is their restart and recovery program? You look at point 32 in Massachusetts, they suffered almost 120 days of losses because they didn't have a robust restart recovery program. You know, you really have to think about, how am I up and running in 48 hours? And paying the ransom isn't going to do that for you. You know, you need to be able to bounce back.
Yeah.
So
there's
I think there are always security concerns, but for me, everything interesting about fire is what happens to it on the device. You know, think
Exactly.
of all the interesting personal lawsuits that are going to come from that.
Well, I was
Well,
thinking more, you know, fire does give you some framework structures for the data management. There are some good,
Yep.
there's some really interesting parts with HL7 on how it structures the data. So, you know, taking another view of that same question, you can combine, if you had a fire, and Google has this, if you had a fire connector that took input from a phone and put it in to be that last mile,
Right.
you're actually all of a sudden getting it to be compliant and ready to be combined with an EMR system. So I think there's some good things about understanding fire. I think for that first mile, maybe not necessary, but it is for the last mile. And maybe, you know, for the participants, one of the things we are going to talk about next week is that last mile. Maybe you don't need to have that done by the end of September. I'd love by the end of the hackathon, but I think it's a worthy goal to understand what it sits at. And my apologies, Amanda, I walked over you as you're about to talk.
No, perfect. Actually, I was going to say, so on the podcast as well, Evan sort of addressed this too. I think fire is a great way of structuring and giving sort of a basis guideline. But if you are one of those people who are building these systems, you also have to be a lobbyist to some degree, because there is the way that it's structured. And Evan talks about this in a much better manner than I can, from his perspective, because he has designed the system. You know, as you're designing these systems, you're going to find that there is what fire wants, but then there's also what makes it easier for the practitioners. And you have to become a lobbyist to really impact and change some of these guidelines as well. So, you know, it's a good starting point. It's not the end all be all. And I think the more as we all work on these problems, we can all collectively change, you know, the rules around fire so that it is a better experience and better area to define it. Because there are the people that create these laws who have not taught technology themselves, who think that this is the way to design a system. And then there's the people that actually design the system. They're like, hold on, this doesn't work the way that you expect it to work. So there is also that myriad problem of kind of playing devil's advocate when working with these types of guidelines.
Sure. Yeah. And with that, if there's no other questions, I'm going to give the audience their evening or their afternoon back. And once again, Scott, Amanda, as always, appreciate having a conversation with you. And I hope the audience got as much out of this as I did. So with that, thank you for attending.